patient today is AA, who is a 63-year-old female, presents with a rash on her lower left extremity. The rash has been spreading for the last 7 days, and she has a fever as of 2 days ago. Her past medical history includes asthma and seasonal allergies. Her family history is not pertinent at this time. Her social history, she denies smoking and illicit drug use and admits to drinking 3 alcoholic beverages per day. She takes montelukast sodium 10 milligrams, 1 tablet by mouth at bedtime, albuterol as needed, 2 puffs every 6 hours, levocetirizine 5 milligrams, 1 tablet by mouth at bedtime, and she also has an EpiPen 0.3 milligrams IM as needed for any allergic reaction. Her allergies include clindamycin. She has an anaphylaxis reaction. Her immunizations are all up to date since childhood. She also has the pneumonia and flu vaccine. Her review system shows left lower extremity tenderness, and her physical exam, the pertinent information was the skin is non-purulent with a rash, cutaneous erythema, edema. It's palpable and yielding with demarcated borders. The assessment shows her to have moderate cellulitis. Her vital signs include her heart rate being 65 beats per minute, her respiratory rate 18 breaths per minute, her blood pressure is 124/80, her temperature today is 102.2 degrees Fahrenheit, her height is 63 inches and weight 200 pounds. We calculated a BMI to be 35.5 kilograms per meter squared, and her creatinine clearance is 62 milliliters per minute. All labs are within normal limits except for the increased white blood count, which is 13,000. Per the IDSA 2014 practice guidelines for SSTI, soft skin tissue infections, the patient has a SIRS score of 2 due to the increased white blood cell count and the fever. She is qualified for IV therapy. The respiratory rate is less than 20 and the heart rate is less than 90. So those two vitals are within the normal range for SIRS. The goal of therapy is to eradicate the infection per the IDSA guidelines. And based off of this, I recommend administering penicillin G continuous infusion. This will make it easier on the nursing staff since the 2 to 4 million unit dose is frequently dosed at every 4 to 6 hours. Continue the IV antibiotics until the patient's fever is reduced and white blood cell count is lowered and within normal limits. And monitor this for the efficacy of the antibiotics chosen today, the penicillin G. We also want to monitor for safety, the hypersensitivity and GI side effects, such as any nausea or vomiting. And we'll follow up once blood cultures come back to see if the antibiotic needs to be modified or the spectrum needs to be narrowed. And all other medications that she's currently on are safe to be continued at this time. And we would want to avoid clindamycin due to the anaphylactic reaction.